And we're back. We have Casper Nim. Casper, thank you for coming on. You were actually recommended to us by Chad Cook, who we had a few episodes ago, and his episode, by the time yours comes out, will already be out. But I initially reached out to him for the systematic review that we're going to be discussing today, and he said it would be a disservice if you didn't chat with Casper himself, as he was the primary author. So that's what led me to you. But for people who aren't familiar with you, can you tell us about yourself and what you do?
Yeah, absolutely. I'm a chiropractor by training from the University of Southern Denmark, which is a bit of a different program because it's fully based in a medical faculty at a public university, which I think is maybe the only place in the world where it's like that. So we have a very high status in the healthcare system in Denmark in general. But I didn't really go into practice because it wasn't, to be honest, it wasn't really my thing. So I worked at a hospital for a long time and did my PhD. I completed that in 2021, where I looked at some of these specificity aspects. We did an RCT and we did the initial systematic review. And it led me into a research career. I'm now a senior researcher at the same hospital. I'm also an assistant professor at the University of Southern Denmark. And I'm still doing some SMT work, but I'm slowly diverging into more like healthcare utilization stuff and how do we optimize courses of for patients with spine pain, basically.
Yeah, that's great. And today you already alluded to it, but we're going to dive into spinal manipulative therapy or spinal manipulations. And yeah, I saw that 2021 systematic review and then the most recent one, the 2025, and we may touch on both. But I think the starting point is, let's just have you outline what actually is spinal manipulative therapy for people to just get a baseline definition. And then we can touch on just kind of the main aim of this most recent systematic review.
Yeah. So spine manipulation is, first of all, difficult to say. So I'm probably just going to call it SMT, spine manipulative therapy, much easier. It's a very commonly used manual therapy or a mobilization. Some would call it a mobilization grade 5 if you want to do the Maitland classification system. So basically, the idea is that you externally put some force into the patient's, in this case, spine, to get some more movement. That's the general idea, and that leads to pain reduction. So it's a manual skill that you normally use by hand. You can also use on devices, but normally you use your hands to and basically your full body to kind of twist people around. And normally, if you're really good at it or just average good at it, you get a little popping sound. That's normally the criteria for success. That separates, I guess, SMT from other types of manual therapies, especially other types of mobilizations that we seek for this little popping sound.
And because your training initially was in chiropractic and commonly the term is chiropractic adjustment, are those terms synonymous, SMT and adjustments? Are they essentially the same thing?
I would say they are completely the same thing. But you would find a lot of my colleagues who would disagree with me highly on that. But but in my little world here of academia, I would say they are completely the same thing. There's no difference at all. And we'll probably get down to some of the nitty-gritty mechanics of it later, why we probably shouldn't call it an adjustment. But for me, it's the completely the same thing.
The systematic review that just came out this month in February of 2025 out of JOSBT, I'm just going to read the title. The effectiveness of spinal manipulative therapy in treating spinal pain does not depend on the application of procedures, a systematic review and network meta-analysis. So you kind of give away some of the findings in the title itself, but I guess it makes it catchier. But I initially want to just have you talk about kind of what the aim was, and maybe some of it's explanatory in the title, but what was really the goal of this systematic review and meta-analysis?
Yeah, so the goal was, to put it simply, we wanted to classify different application procedures that we right now use in teaching to see whether any of them, whether any component or any classification actually provided better clinical outcomes for patients with spinal pain. So that was the general idea. classify and see if any classification is superior to any other.
And that's different than the systematic review you had in 2021, which was the importance of selecting the correct site to apply spinal manipulation when treating spinal pain, myth or reality, a systematic review. That was kind of a different aim or different look at the site location versus the specific technique.
Yeah, so there are two differences here. The first one was that we specifically, the only procedure we looked at in 2021 was the site, basically where you aim, where you want the popping sound to occur, if you want to go down that terminology. And in this one, we had the opportunity to expand that into other procedures, and here we use both the thrust procedure, the target procedure, which was the same as in 2021, and also the region procedure, which is not specifically what we looked at in 2021, but here we had an opportunity to look at it. And then there was another big difference in the systematic review we did in 2021. We didn't do a quantitative analysis, so we did a narrative analysis, basically just summarizing the overall evidence, because we had somewhat few studies that directly compares these different target sites. And in this one, with where we used a network meta-analysis approach, which is a very, very difficult mathematical or statistical thing to put down over this data, we had the opportunity to actually compare both studies that directly compared different procedures. So there could be different target sites like we did in 2021, but also studies that didn't compare them, but where we had, one study that did one target site compared to, let's say, placebo, and another study that did another target site compared to placebo. Then we can, through the magic of statistics, merge, like pool them together and then look at what is the estimated average effect between these two, even though the studies actually don't compare themselves against each other. So that's the magic of the network meta-analysis. And for that's this, also a difference from the one that we did in 2021.
And for this review, the most recent one, what actually did you all find, and what were some of the key takeaways?
I think that if you want to, let's start from the end, but the key takeaways. I think it was pretty simple to say that we found two main findings. One, our review echoed the reviews that had been published earlier, the more general, the normal systematic review, so to speak, the effects studies, right? That we saw that when provided in studies, manipulation is as effective as other guideline recommended therapies, such as education, exercise, other manual therapies. There's no real difference between them. I mean, if you do something that makes sort of sense to the patient, they will probably get the same result in the end. So we saw that. And then we saw this when we did all these different networks and compared these different categories of these different procedures, that there were actually not any differences at all between them. And because we had so many studies, that we had a somewhat good confidence in our findings, but overall we had low certainty of the evidence, which we will probably come back to in a little bit, what that actually means and why we still can conclude what we can conclude. So that was the two main findings, I would say. One is the average effects appear similar to other recommended therapies, and then independent basically of how you deliver the thrust, in what target site you do it, and even in what region, spinal region you do it in, doesn't really seem to matter.
And maybe a paralleled example for people trying to picture this is with exercise and movement in general for spinal pain, where there's beliefs or camps that think specific exercises to the portion of the spine need to occur, or specific extension or flexion or repetitive based motions are inherently superior than just general aerobic exercise or Pilates or yoga. And then kind of zooming out and looking at all of these different movement or exercise based options, they kind of are similar. So is that fair to say that that's kind of a paralleled example for spinal manipulative therapy, where a variety of options can be beneficial, but one's not inherently superior than another?
Yeah, I would say that's pretty much spot on. The review there, also a network meta-analysis by Jill Hayden, I believe, came out in 2022 from the big Cochrane group they're doing right now. They had more papers than we did. Exercise is bigger generally than manual therapy in the research world, but they came out with the same findings, almost small. They did find some small differences between the interventions for exercise, but overall, like big picture stuff, it didn't really matter for on average for patients either what kind of exercise they introduced there, and we actually found the exact same thing. But here was specifically looking at only the popping manipulation, so to speak. We didn't include non-popping manipulation in this review.
And you also alluded to the fact that the I guess confidence is low certainty evidence or low confidence with some of these findings. Is that because most of these papers had pretty high risk of bias? I think you in the paper wrote 83% had high risk.
Yeah.
Is that why the certainty is relatively low?
I mean, there's more to it than that. It's first of all, the certainty is a complex thing to do, right? That's why we have the grade system in effect systematic reviews, and in network meta-analysis reviews we use this cinema approach, which is like an extension, so to speak, to the grade system. So it does take into some of the same factors, and one of the things that we're looking at is risk of bias, and it's very difficult. In the studies that we included here, it's very difficult not to get a high risk of bias when we use the Cochrane risk of bias tool like we did, because one, all the outcomes are patient reported, which means they're not blinded to the intervention, basically, because providing a sham manipulation is nearly impossible. So automatically, most of the trials will be high risk of bias. And then another thing is that we included 161 trials in this review from all over the world, from all kinds of different universities and schools and what have we, and there was a lot of variability in the comparisons. So some studies had major effects and other studies had minor effects, even though they kind of compared to the same thing, which did include a lot of heterogeneity in our findings, which also relates to the low certainty evidence. And then the final thing is that, like we saw in our 2021 review, we don't have that many studies comparing these different types of manipulation. We do have some, enough to do the analysis, but we're still limited by the fact that we didn't have as many as we had studies where we used this indirect evidence. So that was the study I told about earlier, right? When we compared two different procedures against the placebo, and then we can mathematically compare them. But the heterogeneity we saw in the findings was mostly related to when you compared SMT to some other intervention. That was where most of the heterogeneity was. When we compared within the SMT arms, it actually wasn't that bad. When we looked at the statistics that you would normally do to look at assumptions, whether it's a good network or not. So that's what drove it down, and it will drive it down for that reason, and as it should.
Because these findings.
Oh, sorry.
Go ahead.
No, I just want to add something here, that this was an absolutely horrendous amount of work, and we did a lot of extra stuff to validate our findings. That's why the appendix file, I don't know if you opened that, but it's more than 300 pages long. Absolutely horrendous. And I think right now there's a tendency in our research world, especially in health science, that we do more and more of these network meta-analyses. I think it's almost 400 of them were published between 2020 and 2023, I think. And they're extremely difficult. And I would say we have the benefit here of being able to compare within a single intervention. But studies that looks at 10 different interventions, trying to find out which one is the best one, I have a hard time seeing how they actually produce, good science that we can directly implement into reimbursement systems or clinical practice or whatever we have. Of course, they can give an idea, right? But overall, it must be really difficult to to do some of those. There must be a lot of variability in their findings as well.
Because the findings are what they are, and I think it's alluding to the SMT doesn't have to be hyper specific to experience symptom relief, and there's a lot of options for individuals that want to receive and or provide this type of care. Let's maybe provide the other context of what is commonly described as the benefit, or what's exactly going on with SMT or adjustments, and what now with all of this evidence should be a more productive or useful narrative as to what it's actually doing and not doing.
So those are two very difficult questions. If you want to start with the mechanistic one, when I teach, I have a single. We don't teach that much SMT theory. But when I do teach my students, I usually ask them first time what happens, and we get a bunch of different answers, ranging from placebo to bones being put in place. These are somewhat young, early university students, but in the end, I basically just have to tell them that we don't really know what's going on. We have a lot of small studies, some looking at biomechanical effects, some looking at neurophysiological effects. We're slowly beginning to open up the world of more contextual effects as well. So we have a mix of different combinations, and sometimes we see these changes in the tissues, and other times we don't. And something is done in humans, and something is done in animals, and we don't really have that, that smooth transition that you would like to have, where you find something in animals, then you apply it to humans, and then you see whether it has clinical meaning. Because it's so difficult to provide a sham, and because of low funding, and because of a lot of different factors, we don't really have that clear path going from these basic science studies over to clinical mechanistic trials. So that's hampering us to say what's really going on. So I cannot give you a precise answer, to be honest. I would also say it's not completely my field. You can find way more people who does, spines, and they push them and pull them apart and stuff like that. And they even look at right now the disc, and they do a lot of different stuff. But overall, I would say we're nowhere near being able to say what exactly is the thing that works, other than likely a combination, and likely a combination for some people that's different than the combination for other people. So between biomechanical and neurophysiological and contextual is probably the reason why it works. And then we probably have to, I would say, adjust between these different factors for different people, which of course is really difficult when we don't know what the mechanisms exactly are. And the second question was,
well, before that,
Yeah.
I think that seems to be paralleled with exercise as well. The symptom relieving benefits, especially for spinal pain, of what is exactly going on. It's like you probably said for SMT, it's this varied cluster of probably reasons, contextual factors, the actual some like physiological or biomechanical input or effects, some of the belief aspects, some of whatever it is. And so, yeah, I think a lot of these interventions in general, there's still so much unknowns about the mechanistic effects, but it seems to be a variety of moving variables and largely contextual factors, and kind of the beliefs and expectations going into the treatment seems to play a huge role.
Yeah, and it might actually be even worse in manual therapy than in exercise. I mean, I think most patients understand what exercise is, what it does, and what it doesn't, maybe, hopefully at least. But for manual therapy, people have some weird narratives about what goes on, right? Especially if you ask patients about, it can go all over the place if you ask them what's actually going on and what's going to happen now. And plus, it's a hands-on therapy, and that putting hands on people has a tremendous effect on someone. No matter what you do with your hands, just putting them on there, right? It has different effects on different people that are really difficult to quantify, first of all. So I do think there's a difference there between exercise and manual therapy, although they probably align well in this mixture of varying mechanisms. But because it's a hands-on and you're really close to your provider-patient relationship. It's really close. It's, I would say, easier to build a really good therapeutic relationship. It also has the other added contextual benefits of, it doesn't function like this, but as a clinician, you can go in and feel exactly where it is and say, okay, I'm going to modulate, or I'm going to do something here to this specific site where your pain is located, right? Which is why that some providers of manual therapy really like to say that, we don't provide symptom relief. We find the cause of the pain, because that's what we're doing with our magical palpation. But that does have an extreme contextual effect for some patients, and also for some clinicians, right? Get way more confidence out of it. So it's a complex world.
Yeah. Well, okay. So to that example of the clinician that can say they're finding at what spinal level or where exactly the symptoms are, maybe outside of a patient just kind of pointing at or describing where it is, can clinicians actually determine which spinal level is whatever word you want to use, the thing that needs to be manipulated or focused on? Like, how specific can individuals be to determine that? And is that an accurate statement?
I would say not very accurate, no. There has been a lot of research on this and a lot of systematic reviews on this. And overall, clinicians can, to a certain extent, agree with themselves where to find pain, at least. But like you and I, we wouldn't be able to compare our results to each other. That's not really reliable. So the agreement, again, it ranges across the studies, but overall is not very good. And that's just, of course, one thing, what you perceive that you feel with your fingers. We actually did a study that's under review right now where we're looking at the spine and how it moves when you do put pressure on it. And one thing that is completely wrong, at least from the way that we teach, is that we have this idea that we can go in and we can feel these different segments move like intersegmentally. So you can move L4 over L5, for instance. But in reality, that thing is tightly wound up and it basically bends like a bridge. So if you push on L3, everything's going to move more than if you push on L5, where it's going to move less, almost like a bridge, right? If you jump in the middle of a hanging bridge, it's going to move more than if you jump in the middle of it. And that was just one of the findings. Another one was that even though we added like 10 kilos of pressure on people, the spine moved almost nothing, a few millimeters. So if you want to use those two things in this context and say that you can feel something that's clinically relevant happening within the joints, I have a really hard time seeing that from a clearly mechanistic standpoint.
What else outside of that common maybe confidence that is portrayed as a clinician that they can find these levels or these changes within the spine and quote unquote fix them? What are other things that you're hearing clinicians have said in the past that are just wrong about SMT, or you're hearing commonly from patients about what they believe the treatment is providing to them or doing to their spine?
There is some evidence on this, but now you're asking about my own experience, so I'm gonna probably go down that road a little bit. Clinicians, I've been told a lot of stuff, right? And it boils down from theories that are sometimes, decades old. And if you go, depending on who you talk to, right, it's everything from, of course, in chiropractic, it's the oldest thing is the subluxation theory, which is that, your bones are not aligned and thereby your nervous system cannot flow properly, which limits your innate system, as it's called, which means that basically any type of illness you can consider, diabetes and stuff that has nothing to do with the MSK system, is actually affected by these, joints or bones that are out of place. So they have to obviously be put back in place so the innate system can flow again. That was the original theory coming from chiropractic, and it changed some over the years. It changed into a like people like Leonard Fay, for instance. He's an amazing character. He's like 85 today, still practicing chiropractor, right? And he changed it back in the 70s or something like that into a very biomechanical model where we looked at these dysfunctions in the spine, and that's still, I would say, the most common theory. I will gladly say it's no longer the subluxation system, although it still happens a lot, especially in the US. But for most clinicians, it will be this biomechanical thing where you are, your joints are kind of locked up or they're stiff due to whatever theory you want to put on it, and then the manipulation is going to, create that little bit of gap in the facet joints. And that will lead to all the added benefits of manual therapy, all the manipulation in itself. I think that's the most common theory I hear. And I mean, patient perspectives. I'm not a practicing clinician myself, which I often get, often being put on me as that's a bad thing, because then I don't see it in real life, all the magical benefits. I often flip it the other way around and say, well, I'm also not biased by that, right? So, I haven't talked to a whole lot of patients about it, but there is some different evidence out there about what goes on, and it's pretty much all over the place. But yeah, different factors like getting less stiff, more movement, pain reduction, those kind of things. And it feels super good, right? I don't know how much manipulation you had, but it actually feels really good.
Yeah, the joint popping that you mentioned earlier on, that may or may not occur, the cavitation, what does that actually mean when that noise is occurring? And does that actually change? Have you all studied if that cavitation or the joint noise popping, whatever it is, doesn't occur? Do people experience similar effects, or are these kind of pronounced improvements when they audibly hear that noise?
Yeah, so the first question is what goes on, and we have ideas. I think we have a pretty solid theory that most people in the scientific community believe, which is the increased pressure is going to create this little bubble, and that little bubble formation is going to make that popping sound. And then, when the pressure increases enough, because you pull things apart, right, that it's going to make this it's going to burst basically. But it's probably the formation of the bubble that actually makes the sound. We do have some different MRI studies on that published back in 2015, which obviously is forever ago. But that's the common theory now. And then you ask whether there's evidence that it has an effect. And there is actually some. It's difficult to set up that study, right? It's difficult to say, I'm going to give you this, but not give you the popping sound. That's very difficult. But there are studies that has like secondary analysis that has been published where they say like, in this case, we experienced a popping sound, and in this case, we didn't experience a popping sound. Then you could compare the clinical outcomes. And there was a systematic review published, I believe, last year by Dave Newell. I believe he was a senior author on it. That said that the few studies that are out there, it doesn't indicate that it has like any effect on patients, on these average treatment effects that we see in secondary analysis of RCTs. And likewise, when you compare SMT to other degrees of mobilization, like Maitland, let's say grade 4, grade 3 mobilization, they almost come out the same as well, right? So that's probably the best comparison you can do between the popping and the non-popping sound. But from a more theoretical perspective, I would say it probably matters for clinicians. At least that's my experience, that if you set someone up, you want to do a manipulation, you want to get that popping sound, right? That's the ultimate relief. That's the goal, right? That's what you're going for. And of course, if it matters for the clinicians, then no matter what happens, the context in the room will change, and that's going to impact how the patient feels. But in the few studies that has been done, they haven't been able to find like an average treatment effect of it. But I could imagine that it might impact some clinicians if it doesn't happen. But again, it's so simple that it probably doesn't happen a whole lot. If you wanted to say pop, you do. You get it to say pop, even if you have to do it twice. So
in the education for students that will become, let's say, chiropractors or physios or individuals that can provide this type of treatment, what should the education look like now, knowing that a lot of these prior beliefs or understandings are now incorrect and there's still a lot of messiness and uncertainties? How do you go about, or how would you recommend educators discussing the benefits and then actually teaching, like, how nitty gritty do you get? How general do you get? How do you paint this picture of SMT?
I mean, it's a super challenging question you're asking, and it's something we're working on right now. We're looking at the way that we educate our students, and that's independent of whatever profession, osteopathy, physio, chiro. Everyone should be looking into a paradigm shift in the way that we educate, specifically for manual therapy. I would say also many other intervention applications, but let's keep SMT for now. Here we are we should be looking at a major paradigm shift, starting all the way down from like static palpation and movement palpation, and what you can do and what you cannot do with that, and what impact it has other than simply what you are trying to experience that you're feeling. And that should probably lead out into, I would say, a more generalized approach to manual therapy. I mean, right now we're still teaching, at least some places, where we imagine bones being pulled one way or the other depending on the vector, the force vector that you add with your thrust. If you add a rotational component, if you do L3 and you want to do, let's say you want to hit L4, there's something like assisted resistance. There's a bunch of different theories that doesn't really make sense anymore. And it's not just because we have a lack of evidence saying it doesn't make sense. We have evidence saying it doesn't make sense. So obviously, we as academics and educators should implement that into clinical practice. But it takes time. Stuff like this, it always takes time, right? But that should definitely happen. We shouldn't spend more time on that. Instead, we should teach students still how to use their body. We should teach them about we call it like psycho like motor skills, fine motor skills. We should teach them that still, so they can control forces. And when that's not probably because it matters too much for clinical outcomes, but for some people you want to go harder, and for some other people you want to go not as hard, and definitely you want to go not as hard always. But for some you need, depending on muscle and bone mass, whatever, you may need to add more force into your thrust. And we need to teach them that. We need to teach them how to use their bodies. We need to teach them how to do different techniques, different manual techniques, independent of how and where and how it's done, but with a different focus from this mechanical aspect into a focus of comfort and safety. That those are the two main things. And then third, I would say efficacy, and probably not efficacy as in I want to move this bone, but in efficacy as what does the patient feel and what is the patient expecting me to do here. So that aligns. And there was a beautiful commentary published last year by Roger Carey and a bunch of co-authors, suggesting how this should be updated. Unfortunately, they don't provide any specific recommendations. Just saying we should update this, which I completely agree with. But how you actually do it into a world where you have to update curriculums, you still have to do exams, you still have to measure competencies for students and all that, it's quite difficult. It's not as simple as just saying we need a paradigm shift. And I can't tell you exactly what we need to do today, but we need to do something. And it's going to take a lot of work, and it's going to take years of work to get that implemented. But we have to start somewhere, and I do think that could be it, the starting point.
When discussing this option of SMT to students, as what are indications for when it may be helpful to introduce this type of intervention in a clinical encounter, and acknowledging that there's a variety of options for patients to receive care for, let's say, spinal pain in general, and it doesn't appear that one option is better than another. Is that fair to say first? And then I kind of have a follow-up question.
Yeah, I would say that. As long as you are looking at these guideline recommended care options, I would say yes, they all pretty much, on average, that's important to remember, on average provide the same effects.
From that, how do you then discuss this with students? Of you have a few options within the guideline-based recommendations. What should students think about when moving forward as to determining what are the next steps from an interventional standpoint of, does every patient now need to receive SMT, or does every patient need to receive exercise or cognitive functional therapy or cognitive behavioral therapy? How do they navigate this landscape with patients coming in?
Yeah, I mean, obviously we got to teach them how to, stratify interventions. So if you have a long-term persistent spinal pain patient where everything is just going, almost going to curse, going to hell, probably exercise and manual therapy is not going to provide a whole lot of large effects for those individuals. They probably need more of this, maybe multidisciplinary care or some of these other cognitive things. Like cognitive functional therapy is really much up in the air right now, showing huge effect sizes on these more chronic populations or persistent pain populations, which I do think that makes sense to teach students, absolutely, because those are the patients that are going to cost society the most down the road in long-term sick leave, early retirement, what have we. But honestly, if we look at clinical practices all around, at least the Western world, the bulk of primary care practices, physios, chiros, osteos, what have we, they are not made up of those patients. Like they're made up of healthier patients who struggle with back pain. Like, well, if we're being honest, basically everyone does at some point, some more than other, but everyone is going to experience back pain, right? And I think those simple monotherapeutic exercises here, or interventions, such as exercise or manipulation, are probably where it makes the most sense. Those are also typically the patients included in these different trials, where we see these moderate effect sizes, at least on average. So yeah, teaching students about different patient profiles, psychological screening. I don't think there's anything novel in saying that, and then attempt to stratify these different care models is probably the way to go in education and also in clinical practice. Would be my 2 cents.
There's a common stereotype or maybe archetype of individual that ends up seeing a provider for months or years or even decades because they have the false belief that they need to get their spine put back in place, or their hips or their ribs. And it's an unfortunate just kind of pattern of returning back because of that belief, and also typically just a really strong therapeutic alliance with that clinician that they've grown to get really close to and see commonly. Yeah. If, let's say, the narrative wasn't that, in the case that they didn't believe that it was actually putting joints or their spine back in place, the narrative was, I have some persistent symptoms or I have an acute flare up, I'm going just because I know this will transiently kind of dampen down the intensity of my symptoms. And then they still go and see an individual for, let's say, multiple years or decades on and off, or at kind of a recurrent basis. Do you think that that's an okay thing to occur within the healthcare system if the narratives were to change and not be about this necessity for spinal manipulation or adjustment, as opposed, or in kind of the other, maybe more just accurate description of, I know this is going to kind of feel good, and and that's it. What are your thoughts with that change in narrative, but still having people come in very frequently or for a long time in the healthcare system?
It's a really good point you're making. We are, if we're being honest, we are looking at spinal pain in most cases like a recurrent or persistent condition. You know, it does happen, but it's not in the majority of cases where you have a single episode of back pain and then no back pain ever again. So likely it is a recurrent state, and we probably have to compare it more to the stuff like diabetes and these other long-term chronic health conditions where you always would suggest, self-management as the primary part of your care. And I don't think spinal pain is any different than that. You wanted to get as much patient education in there. You want them to deal with it as best as they can. But sometimes I would say if it comes to flare-ups and they can get that in there and they can get some kind of whatever intervention, now we're talking way across just SMT, but whatever intervention that will dampen it or at least reduce it a little bit, and they can keep on working, they can keep on being a grandparent, they can keep on playing golf or whatever they're doing in their daily life. And if the usage isn't completely insane, if they go a few times a year, for instance, I don't see any issue in that. I think that's actually a pretty good idea, because what also happens in those consultations is that you basically see your therapist almost like a coach, like a manager of your condition. Say you have this issue and everything is okay. Like, they can give reassurance, which I still think reassurance from a provider is better than reassurance you're going to get, from an AI or an app or a homepage or whatever. But that you can actually see, this is a flare up. You had this a bunch of times. It's okay. It's going to go away again. Let's give it, 1, 2, maybe 3 treatment. Who knows? And I think that's okay. And especially if it keeps them living their life, and if it secondarily keeps them away from like opioids and, surgery and these invasive procedures, I don't have any problem with it. What I do have a problem with is exactly what you mentioned in the beginning. If the narrative is that you need to come here to keep your spine healthy, right? That doesn't make any sense at all. And we need to get away from that. Like, immediately, that shouldn't happen anyway. It does happen, unfortunately, many places. But yeah, we should get away from that narrative. But if people want to use physios or chiros as an aid or or whatever you want to call it, like a helpful hand whenever it flares up, I think that's perfectly fine.
Yeah, some of the term I've heard in prior settings is maintenance care, quote unquote maintenance care, that we're going to have you come in preemptively or proactively to provide this maintenance treatment to reduce the likelihood of subsequent occurrences or flare-ups. And I've always had a little skepticism towards that terminology or messaging, because I don't necessarily believe that that's probably possible. More so, if people are coming in and having a general check-in on their general health status, what their routine looks like, addressing any concerns, but the idea of providing preventative or maintenance-based, let's say SMT or any type of intervention, that it's going to significantly reduce the likelihood of subsequent flare-ups. What are your thoughts around that messaging of maintenance care?
I would say it has changed quite a bit over the last few years. In the beginning, like when I was a student and even when I started my research career, I was very skeptical of it. I was like, this doesn't make any sense at all. Let's completely ignore that altogether. But then this, I think, really good RCT came out from Sweden in, I believe, 2021 by Andreas Eklund, I was going to say a good friend of mine, that actually showed that it did have, like, given this maintenance care treatment, actually did have some long-lasting effects for some patients, compared to the I'm just going to call in whenever I feel like it's needed. But there's a big difference between doing the study they did and setting that up, like saying to patients, you should probably come back in 4 months. We can do a checkup, whatever, to having the idea that it's of course difficult to completely prove, but I would say it's very unlikely that it was the SMT itself that actually provided these effects. I think it was exactly what you're aiming to, right? They're coming in, they're being reassured, they're talking about their issues, and then they can go home again. And they saw, less use, they saw less weeks with burdensome pain, et cetera, et cetera. And interestingly, I think in secondary analyses, they've shown that the patients who experience the most gain from this approach is, those with higher psychosocial scores, like lower socioeconomic classes. It's those patients, right, who probably have more issues. Whereas those healthy people who do sports and who, have no issues with work and whatever it is, they actually had a worse effect of coming in like that. So I think there's a big difference there, and something that we need to look more into. I wouldn't say the maintenance care is completely dead. I don't know if I want to call it maintenance care going forward, but the idea that you have a checkup, I think that's something really interesting that we need to explore. But we do need to explore it in a positive narrative. I think that's the most critical thing, that allows for self-management more than clinician fixing.
Something that I think is worth touching on, because admittedly we haven't had any really specific conversations in prior episodes on SMT as a whole. Can we touch on what are the potential risks of spinal manipulative therapy or adjustments, and what should clinicians be aware of and patients of times where it is contraindicated to perform this thrust or high velocity based maneuver?
Yeah, so the risk, it's almost, and again, it's not my research field, but I'm of course somewhat familiar with what goes on. There's a lot of, first, if we want to start from the very bottom, adverse events are quite common when it comes to SMT. They're mostly mild, they're transient. Within 24 or 48 hours, they're completely gone again. But it does happen for like 20-30%. Some studies indicate up to 50% of participants receiving it actually have this small adverse event, this small worsening following the intervention. And I think that's really critical that clinicians understand that and can use that in an education setting. Because right now, at least the idea that I have now is that it almost happens like, well, if it gets worse, it's supposed to get worse, right? That's how it works. If it gets better, it doesn't hurt at all, that's good. That was the idea. So it's almost like a post hoc thing that is being put on patients, where you a priori could say, there's a real chance that you're going to feel worse when you come home, and just know that's completely normal. So those are the most common adverse events. And what's even more interesting, that a study published by Katie Pullman, I think at the end of last year, was that actually in most of these cases, patients do not tell clinicians about their adverse event. I think that was probably the most interesting take from that paper. And it goes down to, are we not educating well enough? Like, how come that doesn't happen? That should really happen. That, deterioration right after treatment. I think that's something as a clinician I would like to know. But so that's definitely something somewhere we can improve, and that was both physios and chiro, something where we can improve on. And then of course, whenever we talk about SMT, especially to the cervical spine, we always talk about strokes, right? Because there are being published case reports, I would say almost monthly, about patients receiving chiropractic adjustments and then getting a stroke. And then of course, and this is quite common, and I know this well because I have a lot of colleagues who look at these quite carefully. Oftentimes it's not even a chiropractor who does it. Sometimes it could be whatever. It could be physios. Most times it's massage therapists with no real formal training, like allied healthcare professionals. Sometimes the temporal causality is completely off. Like they had adjustments a month ago and then they had a stroke 4 weeks later, which again mechanically doesn't really make sense. And on top of that, there's actually quite a lot of evidence now, both epidemiological evidence but also mechanistic evidence, saying that it's very unlikely to have a causal relationship between the stroke and the manipulation. I'm not going to say that it cannot happen. I don't think we can that completely, because it does happen at least a few times, right? I mean, in Denmark, I think we have about 370,000 consultations at a chiropractor each year. And in like 98%, 99%, they're going to provide spine manipulation. And we likely have between 0 and 1, sometimes 2 cases a year where the stroke happens directly after. So I'm not going to say that it's impossible, but right now the evidence is pointing towards that it's most likely patients who come in with neck pain, who come in with headaches, who has some kind of cervical arterial issue, and then they get treatment, and then it deteriorates for them. And again, when you look at the epidemiological evidence, there's no real difference whether you go to your GP, where certainly nothing happens like that, or you go to a chiropractor and get your neck twisted and turned and rotated. So I would say as a provider or as a patient, I wouldn't worry about it greatly, but this is where education comes in. There are certain factors that we simply need to understand and we need to look at, to make sure that we, and that's always what I try to tell when I talk to clinicians or students, that if you're in doubt, just don't do it. Do something else. Go to the thoracic spine, work on the muscles, do whatever else you want. Don't twist and rotate the neck, if anything, just for legal reasons, right? I mean, the clinical outcomes are more likely going to be the same on average anyways. So just do something else. Be on the safe side.
The SMT, other contexts where it may not be warranted or contraindicated, are there other special populations, whether it's someone who's pregnant or someone who has osteoporosis? Are there situations where it's definitely a no-go for providing this type of treatment?
So this is where it gets difficult, because when we look at the mechanistic evidence, what actually happens inside the spine is it's minimal. It's almost nothing. And the forces being transduced from the provider's hands into the spine, it's also minimal. So I would say, like, pure contraindications, there are probably limited of them, but I would definitely keep my hands away from like severe osteoporosis or highly evolved rheumatoid arthritis. I probably wouldn't go near the neck because of the ligament loosens up on the atlantoaxial ligament. I would say those are some of the, I would probably call them like full-on contraindications for doing it, but there's not a lot of them. Of course, there's if you get a compression fracture, you probably don't want to provide manipulation right on top of that, right? But a few segments away, I don't think it would matter. But this is where force time modulation is important for students to learn. Like, when do you use little force and when do you lose a lot of force? And you want to go as low force as possible and then see how the patient reacts to it. If that makes sense.
That does make sense. Casper, what else around this topic do you feel like is worth discussing that we haven't touched on, if anything?
Maybe we could talk about future research a little bit, even though I know it's probably mostly clinicians who listen to this, but an individual researcher might sneak in. So I want to say we published a commentary last year about research waste in SMT research. And it's unfortunately very common. It's also very common in exercise, but let's focus on SMT for now. It's very common that we produce basically crappy research that doesn't really lead us anywhere. And we at least make the case here in our paper that we're discussing here, the network meta-analysis, that we don't need more of these small little trials, either comparing one type of SMT to another type of SMT, or comparing the classic, I'm going to call it, just to be a little provocative, I'm going to call it the classic PT study, where you compare one intervention to another intervention so you always win. I don't really think we need more of those mono interventions against each other, or different categories of interventions against each other, because we know the results already. Either one thing or the other, almost previously, is going to be a little bit superior. But if the trial is done correctly, there's likely not going to be any changes. So we need to understand, how do we implement some of this manual therapy? Like the discussion we had earlier, how do we actually implement it where it makes sense on a patient level? Like, who are the responders to it? What are the mechanisms of it? If we understood the mechanisms better, we would be better able to predict who should have it, and in what kind of treatment stratification should you provide this treatment. I think those are the things that are going to be critical going forward here. And unfortunately, when you want to examine stuff like that, it requires large trials, it requires large amount of external funding, which is very difficult to get for MSK in general, and especially if you want to look at something this as concrete as this.
Yeah, do you actually foresee this happening, and in 10, 20, 50 years, treatment will look substantially different, or these pathways or types of care per individual will be much different? Realistically, what do you see happening?
In 20 years? I'm going to be naive and optimistic and say I hope they're different. I hope we're better at giving patient education. I hope we're better at providing self-management strategies and figuring out a way that we can use manual therapy and other types of interventions basically in the most meaningful way. Are we going to change the complex completely? I don't know. The next 20 years, we're going to be a lot more older people. And that is going to be a really interesting thing to follow and see what happens. Like, how is that? First of all, it's going to put a lot more burden on the national healthcare systems, the hospitals and what have you. So it will be really interesting to see, how something as not redundant, but something so non-life-threatening as back pain is going to be managed on a more, societal scale in 20 years, where, unless, Ozempic is going to go completely off here, we're going to have a lot of more obesity than today. We're probably going to have more older people, like more comorbidities. It's going to be a really interesting, it's going to be a super interesting field that we're looking into here. But that's a little bit across the SMT discussion.
You had mentioned earlier on that you're kind of shifting some of your research interests and time away from some of this SMT research. What does research look like for you moving forward?
I think I still want to do some of this SMT stuff, but I'm mostly doing it on a hobby basis now. As every researcher, I work quite a lot. Like, here is a Friday night, right? Saturday night here, so that's not an issue. I still want to do some of this because I do think it's interesting. I think we have a golden ticket to de-implement something here that can actually improve patient care going forward. And I think those are the things that I want to look more into, the overall patient causes and how come some people seek care and others do not seek care, and this economic disparity that's going on in our field. Like, what does that matter? Who should have treatment? Who shouldn't have treatment? And stuff like that. So the more the overall causes, I think I want to go up a little bit on the ladder or take a more helicopter perspective or whatever you want to call it. And I think one thing is for certain that I did some experimental research doing my PhD and stuff like that. I will probably get away from that now because I have to make a decision. Right now, I'm lingering between epidemiology-based stuff and mechanistic stuff, making me an expert of none of it. So I probably has to move on to more of this clinical research more than the mechanistic research.
Casper, I thought this was a great conversation. I think this is a good place to stop. I'll link your two systematic reviews, the 2025 and 2021 piece. I think they're both extremely helpful for people to actually read in addition to just listening to this conversation. We'll call it here. Thanks again, Casper.
You're welcome. Thank you for having me.